Colorectal cancer occupies a strange and frustrating place among cancers. On one hand, it is one of the most preventable cancers that exists because it usually grows slowly from a benign precursor that can be found and removed before it ever becomes dangerous. On the other hand, once it progresses past that early stage, it becomes one of the harder cancers to treat successfully. That gap between highly preventable and highly lethal if missed is exactly why awareness matters so much. A disease that's shifting younger. For decades, colorectal cancer was thought of as a disease of older adults. That picture is changing. Rates among adults under 55 have climbed sharply over the past 20 to 30 years, roughly doubling in that window. It has now become the leading cause of cancer death in people between 20 and 49 in the United States, a statistic that would have seemed almost unbelievable a generation ago. The numbers around timing are stark. When colorectal cancer is caught while still confined to the colon, 5-year survival sits around 91%. Once it has spread to distant organs, that number collapses to roughly 13%. Nothing else in this disease matters more than catching it early, which makes recognizing symptoms and not brushing them off a genuinely life or death skill. What's actually happening in the colon? Most colorectal cancers don't appear out of nowhere. They typically begin as a polyp, a small clump of cells growing on the lining of the colon that starts out completely benign. Over years, a subset of these polyps can accumulate genetic changes that push them toward malignancy. This slow timeline is a gift, in a sense. It creates a long window during which a routine colonoscopy can find and remove the polyp before cancer ever develops. Few cancers offer a screening test that doubles as the cure, but colorectal cancer does. Symptoms worth paying attention to. A change in bowel habits that won't go away. A few days of looser stools or a bout of constipation is rarely meaningful. Everyone's gut fluctuates. But when diarrhea, constipation, or an alternating mix of both persists for more than 2 or 3 weeks, it deserves attention. The colon's job is to absorb water and shape stool. A growing mass disrupts that process. A tumor can irritate the bowel lining and speed up transit, causing diarrhea, or it can physically narrow the passage and slow things down, causing constipation. Swinging between the two can suggest a mass that's intermittently blocking the colon. Unexplained weight loss. Weight can drop for 2 separate reasons here. A tumor can physically interfere with how well the intestine absorbs nutrients, and separately, cancer cells are metabolically demanding. They release signaling molecules that redirect the body's resources toward their own growth at the expense of everything else. Losing weight without changing diet or activity is worth a medical evaluation regardless of the cause. Blood in the stool. This is one of the most recognized warning signs, though it's important to keep perspective. The vast majority of rectal bleeding comes from far more mundane causes, especially hemorrhoids, and sometimes from diverticulosis, small pouches that form in the colon wall and occasionally bleed. Still, blood in the stool should never be self-diagnosed as probably hemorrhoids. It needs to be checked out properly rather than assumed away. Dark or black stools. This coloring usually points to bleeding higher up in the digestive tract, the stomach or small intestine, where blood has time to react with digestive enzymes and darken before it's passed. But bleeding from the right side of the colon, the ascending colon, can also produce this darker appearance, so it isn't automatically ruled out as a colon issue. Iron-deficiency anemia. Some tumors bleed slowly and continuously without ever producing stool that looks visibly bloody. Over months, that quiet blood loss depletes the body's iron stores faster than they can be replenished, eventually showing up as anemia on routine blood work. Iron deficiency has plenty of ordinary explanations: low dietary intake, heavy menstrual periods, kidney disease. But in men, or in anyone without an obvious cause, colon cancer is something a doctor should specifically rule out. A persistent feeling of incomplete emptying. Medically called tenesmus, this is the sensation of needing to pass stool even right after doing so. It happens when a tumor, particularly one lower in the colon or in the rectum, presses against the bowel wall or mimics the feeling of retained stool. It's easy to mistake for a garden variety issue like IBS, which is exactly why a symptom that lingers for weeks shouldn't be self-managed indefinitely. Persistent bloating and gas. A tumor large enough to partially obstruct the colon can trap gas behind it. It can also disrupt the normal fermentation process and the balance of gut bacteria, and a slower transit time gives bacteria more opportunity to ferment undigested material, all of which can produce bloating that doesn't track with any dietary change. Bloating that persists for weeks without an obvious trigger is worth mentioning to a doctor. No symptoms at all. Counterintuitively, this is the most common presentation of early colorectal cancer. The disease often has to reach a fairly advanced stage before it produces any of the symptoms above. That's precisely why screening, not symptom watching, is the real front line of early detection. Waiting for a symptom to show up means, in many cases, waiting too long. Screening: what it looks like and when to start. In the United States, average-risk adults are now advised to begin screening at age 45. Two main paths exist. Colonoscopy, the gold standard, involves threading a thin, flexible camera through the entire colon. If a polyp is found, it can typically be removed on the spot and sent for analysis, meaning the screening test and the treatment happen in the same procedure. The trade-offs are the bowel prep the day before, a small risk of bleeding or perforation, and the minor risks that come with sedation. Stool-based tests, such as fecal immunochemical tests or stool DNA tests, offer a non-invasive alternative that can be done at home. They're less sensitive at catching polyps and early cancers than a colonoscopy, and they need to be repeated more frequently, anywhere from every year to every 3 years, depending on the test. Any positive result still needs to be followed up with a colonoscopy. Neither option is inherently better for everyone. The best test is the one a person will actually complete, so it's worth discussing the choice with a doctor. Age 45 is a ceiling for average-risk individuals, not a floor for everyone. Screening should start earlier for people with inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, and for those with a family history of colorectal cancer or high-risk polyps, typically at 40 or 10 years before the age at which the youngest affected relative was diagnosed, whichever comes first. A relative diagnosed at 35, for instance, would generally mean screening should begin around age 25. The bottom line: colorectal cancer rewards vigilance and punishes delay. Persistent changes in bowel habits, unexplained weight loss, blood in the stool, unusual anemia, a constant urge to go, or bloating that won't quit are all reasons to see a doctor rather than wait it out. But, because the disease so often stays silent until it's advanced, screening on schedule, not symptom watching, remains the single most powerful tool for catching it while it's still highly survivable.